Certainly it's a pleasure to be here. I'm going to be presenting Daigo's disease, clinical manifestations mimicking vasculitis, rheumatologist's perspective in this multidisciplinary approach. So a brief overview. In 1941, Kohlmeyer described the first case of a 21-year-old male with papular skin eruptions and multiple intestinal perforations. Daigo's disease goes with various other synonyms, including Kohlmeyer-Daigo's disease, malignant atrophic papulosis, atrophic papulosquamous dermatitis, and fatal cutaneous intestinal syndrome. Approximately 200 cases have been reported to date. Males have a higher incidence than females. There is an age peak of about the third decade of life. However, there have been case reports ranging from 3 weeks to 67 years of age. Daigo's disease has predominantly been reported in Caucasians, but has also been reported in African Americans, Asian, Indian, and Japanese patients. The average disease course is about 2 years, especially that of the malignant variant. Case reports of patients with the benign variant have been reported, with a survival of over 15 years. Death is usually due to intestinal perforation or cerebral infarcts. The clinical presentation is fairly multisystemic, and the organs most commonly involved are the skin, followed by GI, CNS, heart, lungs, eyes, and kidneys. Joint manifestations, including arthralgias or fluctuating arthritis, have been described, though the exact clinical significance is not well defined. The skin is usually described by patients as fairly asymptomatic lesions. These lesions are predominantly located on the trunk and extremities, and they may include the genitalia, sclera, and mucous membrane. The classic skin lesion is described as an erythematous papule, about 2 to 15 millimeter, with a porcelain central area of necrosis. The gastrointestinal tract has been reported in 60% of the cases and is the most frequent cause of death. The GI manifestations, however, can range from dyspepsia, abdominal distension, abdominal pain, acute pancreatitis, intestinal obstruction, GI hemorrhage, and acute surgical abdomen due to perforated viscus, the latter of which usually contribute to the morbidity and mortality of these patients. The central nervous system is usually involved in about 20% of the reported cases. The manifestations here are also fairly heterogeneous and can range from headaches, transient ischemic attacks, seizures, subdural hematoma, neuropathy, and cerebral infarcts. The ophthalmological manifestations can range from ptosis, diplopia, nystagmus, ophthalmoplegia, afferent pupillary defect, visual field loss, optic neuritis, and papilledema. The fundus exam has been described as having optic disc with vascular tortuosity or optic disc pallor. Fluorescent angiography shows ciliary retinal arteries anastomosed to the retinal arteries. The intrathoracic manifestations can include both the pleura and the pericardium. The pleural fluid is usually described as a transudate with fibrous pleural adhesions. Pulmonary function tests are usually of a restrictive pattern. Pulmonary infarcts have been reported. Pericardial effusion and constrictive pericarditis have also been described. The renal involvement can range from renal infarcts to acute renal failure. Histopathology in these patients have shown concentric intimal proliferation, narrowing, and occlusion of the arteries. Obliterating endarteritis of the bladder has also been reported. So Daigo's disease, as you can see, is a multisystemic involvement disease with clinical heterogeneity. There is no specific lab test or diagnostic criteria at this time. Rheumatologists are frequently consulted to rule out vasculitis. We presented and published a case in Arthritis Care and Research where this was a patient who was a 49-year-old Caucasian lady. She was transferred from an outside facility due to recurrent abdominal perforations, abdominal pain, was given steroids and Cytoxan, and her primary diagnosis was rule out vasculitis. Now, as you can see in this patient, she had a classic skin lesion described as this porcelain central area of necrosis surrounded by an erythematous papule. Her small intestinal biopsy again showed rare inflamed vessels and the occlusion of vascular lumen by fibrointimal proliferation and organized fibrin thrombi. Sadly, this patient succumbed to the gastrointestinal manifestations and she died of intestinal perforation. So the histopathology in Dagos is fairly classic for this absence of inflammation or sparse inflammation around affected vessels, and the media and adventitia are not involved. This is in stark contrast to vasculitis. The skin shows hyperkeratotic atrophic epidermis with a mucin accumulation in the dermis and scant dermal infiltrate of the cells. So vasculitis is very similar to Dagos in the fact that both of them have multisystemic involvement, variable clinical presentations. The diagnosis in vasculitis, however, is suggested by a combination of clinical, laboratory, angiography, and biopsy. A brief overview of vasculitis, because we have to think of these diseases even in the differential of Dagos. We classify them usually based on the vessel size, large vessel including Takayasus, Behçet's, and medium vessel including polyarteritis nodosa, thromboangiitis obliterans, and primary angiitis of the CNS. And small vessel including immune complex mediated, ranging from leukocytoclastic angiitis, good pastures, cryoglobulinemia, Henoch-Schönlein purpura, and the CTD or the connective tissue disease related, specifically lupus, rheumatoid arthritis, Sjogren's, and the others, as well as ANCA-associated disorders including Wegener's, microscopic polyangiitis, and Churg-Strauss. Now, in the workup to rule out vasculitis as well as Dagos, we usually order serologies including autoantibodies, double-stranded DNA, lupus anticoagulant, ENA, anti-cardiolipin antibody, beta-2 glycoprotein antibody. Of these, the lupus anticoagulant and anti-cardiolipin antibody have been reported in those patients with Dagos disease. However, at this time, there's no direct significance between the two. They are both separate entities by itself, lupus and Dagos disease. Anti-CCP points towards rheumatoid arthritis, as is ANCA directed against anti-proteinase 3 or anti-myeloperoxidase. Cryoglobulins, protein C, and factor V Leiden complete the workup. There have been some case reports of patients with factor V Leiden mutation in patients with Dagos disease. However, the exact significance is unknown at this time. As I mentioned, angiogram is really significant to rule out vasculitis. In vasculitis, you see this classic beaded appearance due to the stenosis and dilation of these arteries. The vasculitic rash is described as palpable purpura, and as you can tell, this rash is fairly distinct from that of Dagos disease. There is no central clearing or the erythematous papule. As is the histopathology is different in seeing leukocytoclastic vasculitis with more of an inflammatory response. Atrophy blanche in lupus, again, I think is fairly distinct from Dagos disease. Again, this lacks the central clearing or the erythematous papule. The serologies obviously would point to the diagnosis of lupus, as well as the histopathology, which shows more of a lymphocytic infiltration around the skin and the vessels. A brief overview on the drug therapies tried in Dagos disease. Immunomodulating agents, including systemic steroids, cyclophosphamide, and Imuran, have been reported by various authors to have been tried, however, not of significant benefit. Professor Dagos had even suggested that systemic steroids may actually worsen the course of this disease. This, again, is quite different from the patients with vasculitis. Anticoagulants including Coumadin, heparin, fondaparinux have been tried, as has pentoxifylline, clopidogrel, fibrinolytic, as well as thrombolytic agents have been tried. None of these have shown significantly any clinical benefit. Of late, nicotine patches have shown some benefit, albeit for the skin lesions, not so much for the systemic manifestations. Antiplatelet agents have been said by many authors that this could potentially be palliative in this disease. Again, this is an off-label indication for these medications and possibly could target platelet aggregation based on the mechanism of the action of both aspirin and dipyridamole. Aspirin mainly by stabilizing the platelet membrane and inhibiting the synthesis and metabolism of platelets, as well as dipyridamole, which actually inhibits the cellular uptake of glucose and adenosine and therefore prevents platelet aggregation. So in Daigo's disease, immunosuppressant therapy is not effective. Antiplatelet agents like aspirin and dipyridamole suggest to retard the process, but may contribute to the risk of GI and intracranial complications. So a brief overview of Daigo's disease versus vasculitis. Both of them are multisystemic with clinical heterogeneity. However, in Daigo's disease, this is more of a non-inflammatory vasculopathy, whereas vasculitis is more of an inflammatory vasculopathy. The skin changes in Daigo's have been described as this porcelain central necrosis surrounded by erythematous papule. Some authors have gone out to say even that this is fairly characteristic of the disease and physicians should be more aware of this skin lesion. Palpable purpura in vasculitis, and again the histopathology in vasculitis shows a more lymphocytic infiltration compared to the hyperkeratotic atrophic epidermis with mucin accumulation and a scant infiltrate. Immunosuppressant therapy is not effective in Daigo's, whereas steroids and cytotoxic agents are the mainstay of treatment in vasculitis. Antiplatelet regimen may be effective in Daigo's, and this requires further research. So as physicians with patients who have Daigo's disease, these are the clinical dilemmas now facing us, which hopefully would be resolved in the future. If we have patients with skin lesions, do you think they should have routine CT abdomen endoscopy? How about routine X-ray chest? Routine labs like CBC with TIF probably picking up anemia at an early stage, or a comprehensive panel targeting the renal dysfunction. Would there possibly be a lab test or a criteria differentiating the benign from the malignant form of this disease? And the most important question, what is the best treatment in this disease? So in conclusion, Daigo's disease is a rare disease with multisystemic involvement. The exact etiology to date is unknown. There is a benign variant limited to the skin, which has a better prognosis. The treatment options, however, are limited. It is therefore important to raise awareness among physicians, patients, and their families, and international collaborative research will be required to provide innovative and evidence-based approaches to the treatment of this disease.
John?
I may have missed it, but what about systemic anticoagulation in these patients?
Yes, they've also been looked into. They've actually tried heparin, coumadin, fondaparinux, but however, these patients have not responded to that form of treatment. In fact, my patient had a GI bleed after she was tried on that.
Actually, the thought that I've had after listening to presentations today is to try nitroglycerin, for somehow kind of dilate blood vessels. I mean, because, certainly, again, I could ask for the case. The aspect I don't report the case, but I don't really know. The nicotine is very interesting. That's actually a vasoconstrictor. So I don't really understand that either. But if I happen to somehow encounter one of these patients again, something which I have not seen used as nitroglycerin or vasodilators, and actually are a few agents which actually just got FDA approval that deal with endothelial cells, so I can't remember whether I can write them down. But I don't know.
So Noah Scheinfeld was talking a little bit about use of nitrates possibly for the treatment of this condition. But it's interesting that there's this contrast with Berger's disease, which we're going to hear more about tonight, where you don't really see the digits being put at risk vascularly in Daigo's disease.
No, but you can look at the pictures, but it's hard to know what it means. That antiphospholipid syndrome has a lot of different findings, none of which really overlap, like splinter hemorrhages and all that. None of them really overlap with Daigo's. Although when you look through the literature, there is an overlap, of some people who have antiphospholipids and have Daigo's-like lesions. That certainly has been reported.
But the angiogram in Daigo's disease has not really shown any sort of spasmodic appearance that could potentially benefit from vasodilation or anything like that.
So the thing is that whatever's affecting kind of Daigo's might negate any kind of dilatory effect you might have. I'm just speculating because I've never seen that used, and I've never really thought about that. I just thrown it out there.
It was interesting that your patient, you described the nicotine patches seemed to make her feel a little better.
For the skin.
So for her dermatologic manifestation.
Affect your GI tract at all.
the ghosts were accepted everybody that it's not a vasculitis. But another disease that is indeed a vasculitis, the Behçet's disease, it has been observed that the people that smoke become less aphthous ulcers in the mouth.
But that has been reported. Aphthous ulcers are responsive to kind of chewing nicotine gum.
Exactly.
Smokers. I mean, but that's reported in the dermatology literature, and that really seems real. I mean, you know, when you look at the papers, that's real. I mean, not that I get to see all that many patients who have Behçet's disease, but that seems real. But again, I can't explain that either.
If nicotine has an anti-inflammatory effect, but on the other hand, that people with the ghost that respond is also a bit strange because we proved that it's not an inflammatory disease, something else.
I'm curious, what does a mesenteric angiogram in this disease show in a patient with GI infarction?
It's more like an obstructive, but they didn't have the beaded appearance that we have in vasculitis. So it's just plain like thrombotic, anything that obstructs the vascular lumen. But they didn't show post-stenotic dilation. There were a few case reports that had the abdominal angiogram that reported that way.
So John Stone is speculating that maybe the vessels are too small for there to be a visible sign on traditional angiographic media.
The key question for clinicians, since there are no patients in the room, is that systemic Dagos is a death sentence, of which nobody has been reported to recover. And again, you said it, that they die in a year to a year, and it's some months before they're kind of detected, and the therapy doesn't do all that much. You can talk about kind of palliation, but I mean, it really is, it's like a tsunami when it hits the patient. I mean, you know, and it's not clear about anything. I mean, I don't know what to say. I mean, it's just really overwhelming. It's overwhelming for their doctors also, because you're so helpless in the face of the situation.